You all to our final webinar of the year. We started the year face to face, and as of March, went into the virtual world, and we've run. I've lost track of how many webinars, but we've given almost 4,000 hours of education, maybe more than that once we total up the rest of the events. So thank you all for being here. I'm going to pass the mic to Anne Claire to introduce our speaker for the evening.
Hi, thank you very much, Mark. I'd like to introduce my colleague and friend, Dr. Reed Pierce. He serves with me, as well as some other folks who are here this evening on the board of the CARE Collaboratory. We have Gary Oftedal, Jean Bate, and Sherry Bright, who are all on the CARE Collaboratory board. So the CARE Collaboratory is very, very happy to provide this webinar via the ACHE Southeast Texas chapter. And Reed is an experienced clinician. He's a healthcare leader, coach, and facilitator who enjoys fostering transformation of organizational culture and complex clinical systems. He is currently chief of the Division of Hospital Medicine at Dell Medical School, and also serves as Associate Chair for Faculty Development and Wellbeing in the Department of Medicine at Dell Medical School. In these roles, he oversees a large portfolio of clinical, high-value care, experience, well-being, educational, and scholarly activities that are aligned with the Dell Medical School mission and vision to create a vital, inclusive health ecosystem, which is what we're going to talk about this evening. So Reed, I'm going to send it off to you. Thank you very much.
Thanks, Anne Claire, for that very kind introduction. Thanks everyone for being here, finishing out the year. Particularly pleased that it sounded like many of you made it through the wine pairing session to this session. I will work hard to make it worth your while. It looks like there are a little under 30 people on right now. So this size is actually very conducive to a group discussion and some engagement. I'm not going to talk at you for the next 90 minutes. I really want to create a conversation using a framework around well-being that some of us have been talking about across the last year or two. Let me first share my screen and make sure people can see it. People see slides there?
Yes, we do.
Thank you. All right, great. So I want to first just put out in the spirit of disclosures, because I think we are potentially doing CE credits, that part of the work that I've been able to do in the last 3 years has been with the National Task Force for Humanity and Healthcare, one of the groups that convened to think about how is the workforce doing in American medicine. And I'm going to reference some of the insights in the work from that organization later this evening. Task Force received funding from Vocera Communications, the American Hospital Association, and the Institute for Healthcare Excellence. We're going to spend a little bit of time setting the stage and then talk about stress and its impact in healthcare, a very timely topic in 2020 as we finish what has been a challenging year and look at least a few more months, I think, of significant stress on the system despite the vaccine that's arrived this week. Talk about what an ecosystem represents as a mental model, and then really spend most of our time having a conversation about how the ecosystem model can help us conceptualize ideas around well-being, stress mitigation, and leadership in particular. So I wanted to start here, inviting people to come into the conversation and maybe get a little bit of an emotional reset. I'm sure all of you are coming from busy days. So even amidst the challenges of 2020, I'd like you to think of a time in work or life recently when you either experienced a moment of awe, something that really sort of struck you with awe, or you experienced a moment of amusement, or you experienced a moment of inspiration. So a moment of awe, amusement, or inspiration in work or in life. And then when people are ready, if you would type into the chat, which one of those emotions did you experience, awe, amusement, or inspiration, and write a short sentence about how it impacted you. So an example might be, I felt inspiration, seeing my colleagues come in and work on their day off gave me energy to keep going. That's what inspired did for me. So whenever you're ready, type your emotion and the sentence describing how it impacted you in the chat. So seeing some examples coming in. Great, so a number of examples that talk about how your organization may have responded to the pandemic or contributed. Awe from being outdoors from Sherry, living in a place with beautiful sunsets. Yeah, awe thinking about what we've accomplished, having 100 ventilated patients in one hospital during the pandemic. Let's get a few more examples there of impact. Amusement over adapting to telehealth, something I think many of us have experienced and worked through together. Inspiration watching people do their work together. Great, so thanks for starting our time together, reflecting on some experiences where we tapped into the human side of what we do every day and how when we do that, it has an impact on us because there's so much in front of us in American healthcare, particularly in this year. Some of it's about fundamentals. Do we have enough staff, supply chain? Do we have PPE? Some of it's about science and technology. Some of it's about deploying new business models, a lot of financial pressure. And yet through all of that, the human experience has been central to what all of us have walked through over the last year. It impacts the people who work with us every day. It impacts patients and families. And I want to make that idea of the human experience and stress and burnout and well-being part of the front and center aspects of our conversation through the rest of the evening. So we're going to circle back on these emotions and what getting in touch with them does for us here in a few minutes. Wanted to invite an opening reflection, another opportunity for people to type in the chat if you would. What are the causes of stress in healthcare for you or for the people you work with, you talk to every day? So let's get those out on the table.
He's here. He's doing good. He tries to get his steps in, and he's doing research.
Someone who's perhaps on the phone with someone else, if you wouldn't mind muting, that would be great. Thank you. All right, so examples of causes of stress in healthcare. We got short staffing, reimbursement in private practice, information overload, exhaustion, ability to take care of everyone, make them well. Yep, too much to do, too little, dealing with a lot of death, particularly in the last year, burnout, endless stream of patients, particularly patients with COVID-19, among other things. So lots of reasons to feel stress out there. Let's link that over to burnout. And I just want to ask, in your perception or your experience, what's the connection between stress and burnout? Burnout was mentioned as a cause of stress, but let's explore a little further how those two things are connected. So again, put in the chat what you think the connection may be between stress and burnout. So money in there, adapting to varying personalities. Yep, knowing that our people are really stressed, not only at work, but at home. What are the connections do people see between stress and burnout? So yeah, how we manage stress chronically has something to do with burnout. Duration, intensity of those things, whether or not the stress is interrupted, whether people have a chance to recover. And those feelings, again, getting to human emotion, hopelessness, inadequacy, that has something to do with burnout as well. Disengagement, maybe one of the things we see in the mix. So lots of great thoughts on where stress is coming from, on the fact that stress is related to burnout. And I want to take this one step farther just to connect these ideas to things that, as leaders, we're accountable for, we think about, we're often up at night worrying about, which is indicators of performance in the organizations that we lead. So for a good chunk, I think, of the last 10 to 15 years, as burnout in American medicine has been a bigger and bigger topic, there's been a growing spotlight, more and more research papers, more and more articles in the secular press about the rates of burnout and how people may feel with burnout, there's been a little tension in a lot of the conversations that I've been in behind the scenes, meaning inside organizations. And that tension goes like this. We get that people are saying they're stressed. We get that people are saying that they're going home burned out. But is that just sort of how they feel? Does that really show up on the scorecard of the organization? Is this tied to performance metrics and other things that we are responsible for in the business? And it turns out the science is really clear that burnout is not good for organizational performance, really at any level, at the macro level of the organization, at the unit or clinic level, at the team level, and at the individual level. So this is a short overview of some of the science showing that higher levels of stress and burnout definitely show up in how patients perceive our care. Patient satisfaction scores go down. Hospital-based infections are more common when people are burned out. So higher burnout rates among nurses lead to higher rates of things like catheter-associated UTIs. There are more medication errors. There's even a connection in various ICUs with higher standardized mortality ratios. And it doesn't stop there. It turns out for clinical folks that we can measurably show that diagnostic accuracy and procedural performance gets worse when people are highly stressed and burned out. You get more surgical complications. That is another source of lower patient satisfaction. And then there's all the stuff we see in the engagement scores that we follow in organizations. So morale, engagement, retention, turnover, getting the best out of our teams, all those things get worse. They're harder to do when burnout is high. And there is increasingly, I think, good quantification of the financial impact of at least parts of this, while we're still getting our heads around, exactly how much additional inpatient harm or diagnostic error or low value care practice, where burned out people, for example, are ordering more tests and procedures than their colleagues, how much that adds up to. It's quite clear that when people who are skilled, trained, and highly paid, doctors and nurses as two examples, leave organizations, that's expensive. And we've got studies now looking at numbers like this, that doctors leaving practice or cutting back on practice is something like the equivalent of losing multiple medical school classes every year from the workforce. Some of the work that I did with the National Task Force I referenced earlier tried to quantify this with some economics, using the best available data that we could find in the literature, and then some financial analysis. So this is for physicians. So if you look at lost productivity, meaning you've got less revenue coming in when a physician leaves due to burnout, and you look at replacement costs of recruiting, and you scale that across all the employed physician groups in the United States, you've got annually something like a $3.3 billion a year problem. And if you do the same thing for nurses, just nurses working in hospitals, you've got something like a $9 billion a year problem. So there are many billions of dollars on the table here in turnover alone, which is clearly tied to higher levels of stress and burnout. That, I predict, is only going to be a bigger challenge as we continue to walk through the remainder of the COVID-19 pandemic. We're certainly seeing that in my hospital now, where, as an example, the number of nurses who are working in our ICU is smaller than it was 4 months ago. And some of it has to do with this. Some of it also has to do with the fact that people have left because they, with a travel shift in some other hotspot, can make a lot more money than they might in a current full-time shift. That's a national problem as well. But it's certainly clear that people under stress tend to leave their jobs or cut back, and that has a big financial impact on our organizations. The last thing I'm going to point out, just in case anybody isn't convinced, is that while this hasn't been published yet, one of the people I've had a chance to work with is a gentleman named Brian Sexton. He's a safety and burnout and well-being researcher at Duke University. And Brian is working on a publication right now where the data is, in essence, showing quite clearly that if you look at all the factors in the CMS star rating system, those things that give you, 2, 3, 4, 5 stars, burnout is probably going to be a bigger driver of your total star rating than any of the factors built into the measurement system. So if the workforce is burned out, it is going to be hard to achieve high performance that shows up with a good star rating, which of course is going to impact not only reputation, but probably reimbursement for many organizations. So this is an important topic, and lest I leave you with only depression at the end of 2020, all the bad news, what I want to do is take this idea and actually turn it. We have, for a good portion of the last decade, mostly focused our stress and burnout mitigation approaches on something that looks like here in this picture. Trying to help the individuals who work for us get better or remain resilient. And so we've added things like rooms where people can go to decompress or rest at work. We have tried to do a better job getting people healthy food at work. We've tried to add benefits around things that get people to the gym more often or get them to the doctor more often. All of those are really important. And helping individuals get and stay well is really important. But if left as the only potential intervention to try to tackle these challenges that I mentioned a few minutes ago, two major shortcomings come into focus. The first is that focusing on individuals and trying to promote their well-being and reduce their burnout and their stress only takes us so far. It hasn't taken us as far as we want to go, because if you measure burnout rates in healthcare, whether it's for doctors or nurses or physical therapists or people who work in the volunteer office, everywhere we see the number, it's a high number. It's 30% or higher. So working with individuals alone hasn't gotten us where we want to go in terms of well-being. The other is that for people who are a bit cynical about all this, they will often say something like this: if you set up a place for me to go meditate at work, or you give me a gym membership, you are just trying to put the burden on me to get myself ready to come back and take the beat down, and maybe do so with less complaining. And I'm not really interested in that kind of help if the system isn't going to go first and do something to make this better at the same time. So I think we have to take a bigger perspective. And I'm going to propose that one way to think about this is through an ecosystem approach. So if I borrow from biology and I borrow from climatology, we talk about ecosystems. Those are complex interactive environments, but we can break it down into a few components that become important for our conversation this evening. So a community of interacting organisms or agents and their physical environment. That's the way I want people to think about an ecosystem. And the ecosystem, through that lens, has four components. Physical components. So in healthcare, we've got physical structures, buildings, supplies, materials. We also have digital structures like the electronic health record that we interact with, all these apps that we're using to try to keep people updated about their test results. So that's one component of the ecosystem, but it's not the only component. We also have climate. How does the place feel when you walk into it? So as people were arriving this evening, and we were having a conversation about literal climate, how warm or cold is it where you're sitting this evening? But in our organizations, there's an emotional climate that people are very attuned to. We measure this with patient safety scores. We measure this with a certain degree our engagement instruments. The point is, human beings pick up on the emotional temperature of the place, and that impacts how they feel at work and when they go home at the end of the day. Third component of an ecosystem, individual organisms. So in healthcare, we're focusing here on humans, not healthcare bacteria or other organisms that perhaps are resistant to drugs, but to the human beings, and then the interactions between them. And there are a couple of layers here. There are the individual traits and experiences that people bring. And then there are the interactions they have with other people, other individuals, and those are often shaped by leaders. So leadership becomes an important fourth dimension here in our ecosystem. So I want to spend a little bit of time now getting back into some conversation about how might we address stress, burnout, and promote well-being, the opposite of stress and burnout, through the improvement of physical and digital structures, through enhancing organizational and team climate, through supporting individuals, and through amplifying leadership practices that improve well-being. And the way we're going to do this is I'm going to pose a question to the group, and we'll have a little bit of conversation about it. And then I'll show you a little bit of data to support the fact that working on each of these four dimensions actually has a measurable impact on the things that we're talking about in terms of both well-being and performance. So let me pose this question to get started. And if people are willing to come off mute and share your thoughts, it'd be fun to hear from people, not only read in the chat. So how might we improve physical and digital structures in healthcare to promote more well-being for our people?
The one that seems to bother the medical staff most, but probably the nursing staff as well, is the EMR and the burden of using the EMR.
It's a great example. Comes up every time I'm talking about well-being. This tool that defines so much of my day that I'm interacting with all the time has a pretty high hassle factor, and it stresses me out. And if that thing worked better, my well-being would go up. So great example. What are some other physical and digital structures people could think of that we might work on to improve well-being?
We could design our spaces differently to have more natural light, for instance. Maybe more collaborative and restive spaces.
So say a little bit more, Mark, about the second piece. What would a more collaborative space look like? I think we probably all get the reality of many spaces in our buildings that have no access to outdoor light, and people spend hours a day in those spaces.
Yeah.
What does the collaborative space look like?
Collaborative space maybe is, an area that people can congregate, and it's harder to envision now with COVID, but we were thinking about having more spaces where, like lounge space that you could have conversations with your colleagues, exchange ideas, sit and relax and have a cup of coffee, that sort of thing. And then for my ideas of restive space, but having, places that are quiet, maybe they have a good view, but someplace you can kind of take stock of yourself without all the interruptions and noise and alarms and everything else in our daily environment.
Noise level.
Yeah, say a little bit more there. How's
I
noise
know when
level?
we walk into the emergency department of one of our hospitals, I mean, between the monitors going off and the number of people there, just I was going to say noise and also crowding. It's just a very tense place to be. I mean, you just feel your blood pressure go up when you walk in.
Yeah, so a great example of the interaction between physical stuff. So we've got these machines that monitor people, digital stuff, these algorithms that are set to make a noise or to try to bring attention to what's going on in the machine or on the monitor based on data being collected, and then how that aesthetic interacts with people in the environment. And thanks, Mark, for sharing that. Like, you literally can feel your blood pressure go up, the tension go up as you're in that environment that's gotten more and more noisy chaos. I was really struck by this. I'm an adult internal medicine doctor. So I did all my training and residency with adults, and it was probably 5 or 10 years into my career before I'd ever made it into a pediatric ICU. And I was instantly struck by how much quieter the space is than adult ICUs and how much calmer I felt immediately.
Mm-hmm.
So there's something about noise level and aesthetic that has a lot to do with level of stress in our well-being. Let's see if we can get at least 2 more examples of digital or physical stuff.
This is something you and I have chatted about before, but at Hopkins, they actually did what's called bedscapes, where the curtains in the various different rooms were actually scenes of nature. And when they would do endoscopy, bronchoscopy, they would put headphones on with nature sounds. And what was interesting is that the amount of pain perception diminished and the experience was better. So there was an objective outcome measure by changing the physical environment and the auditory environment. I think that's what you're talking about.
Yeah, it's a great example, Gene. Thanks for that. Maria, thanks for your comment in the chat about adding music or senses or welcoming pictures to the space. I was taking care of about a year ago a gentleman who, for a variety of circumstances, had ended up in the hospital and couldn't go home. Needed long-term care, and had become quite frustrated some 2 months into his hospital stay. And that led to the nurses feeling really frustrated every time they went in the room. Same thing with the physician team. And it turned out we eventually discovered he loved to draw. He was an artist. And when we gave him not only paper on which he could draw, but then had to get explicit permission from facilities to do this, but we found a way to do it safely, a way to put his artwork up on the walls. So his walls slowly became sort of an artistic mural, totally changed the dynamic. He was less stressed, the team was less stressed, but it's not something that I would have thought of, right out of the gates. Not something that we often think of. How do we redesign the physical spaces? More dogs and fewer clipboards. I think that's another great example where pet therapy has become clearly an impactful thing for people in the healthcare setting. Good. So there's plenty of ideas here, lots of evidence that this is good for people. I will say that here's one example from a clinic at the place where I did my medical school and residency training, UCSF, where They just took stock of things like the call management structure and how and where the inbox was managed. And they moved around their clinic schedules, and they literally moved around some furniture and some of the ways in which people walked through the clinic environment and engaged with the physical infrastructure. And you can see here what happened to burnout and to stress before and after. So didn't solve it entirely, but clear evidence that working with our physical and digital infrastructure can have a big impact. Now, I would argue that it's interesting in my experience that this is the thing that clinicians in particular tend to ask for first. If you say, what can we do to make this place less stressful? What can we do to address burnout? People will say, fix the EHR, get me better parking, uncrowd my workspace. These are often pretty expensive and long-term systematic changes. And so while they are important, they can't be the only solution because they take quite a while to bring to fruition in many cases. So one aspect of the ecosystem that we can focus on, let's move over to another. Let's think about organizational and team climate. So would invite, again, comments from folks. How might we enhance organizational and team climate in ways that improve well-being?
Improve communication and decrease ambiguity and disinformation.
So what might that look like, Mark?
So I can speak specifically about COVID and the challenge of communicating, just to letting people know what to expect, what we were doing about it, what the plans were, whether or not we would have PPE, having teams who knew each other. When we were deploying people around New York City to our various hospitals, we didn't send them as individuals. We sent them as a pod, so at least they knew other people that they were going with, to give them a sense of of belonging and awareness of who they'd be in the trenches with.
So heard themes in there around the importance of human connection, particularly if you're deploying people to a new facility, sending them as a team, not just as a one-off. And then the piece around really trying to be as clear as we can about the specific things that people might have on their minds related to COVID. Do we have PPE? How is it available? What are some sort of operational and logistics questions that come up for people that those could enhance well-being, reduce stress? It's great. What are other ways people see to enhance organizational and team climate in support of greater thriving and well-being?
We could actually look at some of the policies and processes we follow and see if they are supporting teams or supporting individual work.
Sure. You have an example from your experience, either of a process that did support healthy team climate or a process and policy that got in the way?
Well, I think, a simple one is incentive systems and performance management systems that tend to reward somebody who is perceived to be the hero, even when a whole team has accomplished whatever the goal is.
So I really like that example and have thought, so I spent almost a decade before my current job doing a lot of quality safety clinical transformation work at UC Health and the University of Colorado. And in that work, ended up thinking a lot about measurement and how measurement, even without being tied to payment, creates its own form of cultural incentives. So wherever we point the measurement, we incentivize certain kinds of behaviors that may move a particular metric like RVUs, encounters, next access, and clinic, but could actually be pernicious for culture and for team climate if we're not careful about it. So thanks, Sherry, for bringing that forward, because I think that's a really interesting one.
I'll add to that really respecting and acknowledging that the real experts are the ones closest to the process. Those folks who are actually doing the work and utilizing their expertise for detection, prevention, correction, as opposed to assuming that the experts are in some kind of leadership role. higher above, so that the real eyes and ears of the organization, and then the ability to work together, is to really utilize that expertise in any way you can to enhance the organizational and team climate, as well as deal with quality and safety.
Mhm. So thanks, Anne Claire, for that. It's really interesting to think about that component, that one of the rewards people may take home in their work is, was I recognized for the contributions that I can bring? Did I have an opportunity to, without fear, share my expertise? And if avenues to do that are closed off, not only does innovation and improvement tend to decline, people go home at the end of the day perhaps asking themselves, was what I did today worth it or not? So a really cool principle that crosses from systems redesign over into team climate, how people feel in their work.
I'd say having a more integrated culture helps quite a bit. Recently, we had to do an IT upgrade, and we noticed that folks on the IT team had a completely different approach to a problem, any given problem, and folks on the clinical side had a different approach to a problem. And measuring the validity of both tends to not be as productive. Rather, if you say, this is why they're approaching a problem this way versus, a different way, and you kind of integrate that and kind of make it more horizontal, then you tend to have better outcomes. IT might understand limitations much better, and the clinical side might have a different perspective of needs since they might be at the front line. And a lot of times we kind of fail to bridge that gap.
Yeah, thanks, Elvin, for that comment. For me, it's such a powerful illustration of, in big complex organizations, and healthcare by definition builds big complex organizations. Each of us is in possession of part of the truth. Much of the time, these processes, these workflows, these integrations, these systems in which we work span, individuals, teams, and departments. And so, what I may see as a clinician, and I'm so convinced is the way to get this done, doesn't actually holistically take into account what the IT team knows. But you're right, if we dig in around, well, IT's right, or the doctors are right, and one person is gonna, or one group is gonna get to sort of make the final go, no go decision, as opposed to saying, how can we put those things together? Can we get on the same page? Can we share information? Can we build a shared mental model? That impacts how it feels, the literal emotional temperature in the organization, right? So that's a great example. And I feel like the IT folks commonly get put into that category. IT is telling us no, instead of, hey, are we building a partnership here that actually makes the organization work better and builds relationships at the same time?
Yeah.
Good. Well, let me show you a little bit of data on this one. So this comes from Michael Leonard. Michael Leonard has done a lot of patient safety work with safe and reliable healthcare. If people know his work, and has a whole host of organizations where a big piece of what he has tried to study is organizational performance, a la, is this a safe place to receive care? But a bunch of the instruments that he has built and validated, one of which is called the SCORE tool, looks at team climate and organizational climate. So how does it feel when I walk into this part of the organization? And this is an example of the kind of data that he and his team often produce, where you take different units in a hospital in this case, and anybody who's got a team climate score above 60 generally is one of those places where people feel good working there. The climate and the organizational or emotional temperature is seen as positive, and below 60, you start to get into trouble. And what the data clearly shows in his work is that the lower the climate score in a particular area, the lower the employee satisfaction is going to be. You actually get more employee injuries on those units. So people probably, because they're not comfortable speaking up or looking out for each other, don't rescue each other when things come up in the daily work of healthcare that might cause somebody to get hurt. Employee absenteeism is way higher in units where the climate is poor. And you've even got things like vacancy rates and turnover that are different. Now there's separate data which matches some of the statistics I showed you all earlier that shows in in systems where you've got these low climate units versus high climate units compared, things like C. diff rates and patient falls and patient infections are also dramatically different. So this isn't just about, again, how people feel and about turnover. It's also about preventing harm in the hospital and achieving the performance that we want. So, so we talked about digital and physical structures as one place we can work to enhance well-being where it has an impact. Working on team and organizational climate is a second. Let's think about this one. So if we think now about individuals, how might we increase capacity and support for individuals to achieve higher levels of well-being or even thriving, perhaps, even amidst high levels of stress at work? What are the things we could do to support individuals in the workforce?
Relieve them of things that they worry about outside of work. So if they're worried about bringing COVID home to their families, or they're worried about childcare, or they're worried about elder care, those things that really just it just adds a level of stress to them when they just show up to work and they haven't even started working yet.
So thanks for mentioning that, Mark. And I think this becomes one of those interesting modern conundrums, so to speak, of the organization. What is the remit of a place of work? If you go with the 20th century model, the workplace should be safe and it should have policies and procedures that protect people, and it should give people a reasonable paycheck and benefits. But now I think we see these connections, right? Are there things that we can and should be doing for our people, even when they're not at work? So can we make the transition home safe if they're worried about potentially bringing COVID home, as one example? And we see this, it's been most popularized in Silicon Valley. Benefits that help people get their lives done, even outside of work, are perceived to have some benefit to individual well-being at work. So some companies pay for things like dry cleaning support or help with childcare. And I know for my institutions, childcare has been another front and center example in the COVID pandemic, where we've said, can we create a way to help support people whose kids are no longer in school, feel like their home life and what's going on with their kids is okay if we're asking them to come to work and take care of patients with COVID. So we've seen things like, childcare centers that have cropped up at hospitals and care delivery systems, whereas perhaps those things didn't exist or were much smaller before. What other examples can people think of where we could increase capacity and support for individuals, even in the midst of stressful work?
Perhaps tagging on to those basic needs that we were just talking about before is a lot of folks are having food insecurity now, and be able to provide some kind of pop-up food bank type of thing at people's places of work, where they can not have to worry about making a separate trip, and a structure it where another family could come by, or they could come by after work, or something of that nature.
Mm-hmm. Yes, thinking about food and multiple avenues here. Can we provide healthy food options at work? Can we ensure that we're taking care of food insecurity where we can through work to again, support not only physiologic well-being, right, but relieve some of the stress that comes with living day to day hungry or worried that you're not going to be able to get the next meal.
I mean, do we just make a link to Maslow's hierarchy of needs and sort of tick them off, address them as we go?
Yeah, I think that's a great way of looking at this, Mark, to say, there are certain things, right, that are at the bottom of that pyramid: security, food, housing. Can we help take care of those things? If we move up the pyramid, what are some other things that would be on your list or others' list to help support people at the individual level?
Reed, I think if we move up to the belonging stage, I think one of the things we've noticed, and Lisa's on the call, and she works with a very wonderful critical access hospital, is just giving people the opportunity to share those fears in that sense of belonging, that we're all in this together. And I take a shower when I get home because I don't want to bring it, and I change clothes in the garage so I don't bring anything into the house. Whether it's based on epidemiology and infectious disease, that's one thing, but it's very emotional. And having a peer group that you can share these kind of fears with becomes very supportive. So that goes up one level in the Maslow's hierarchy.
It's a great example.
I would just add to that I think just acknowledging people, acknowledging for their work, but also acknowledging their fears and their concerns and all these things, just taking a minute to say it gives people a lot more energy.
It's great. So yes, creating human connection, belonging, Jean, to use Maslow's word. And there are lots of ways to do this. It's great to do it around positive things, thanks and appreciation, acknowledgement of hard work, but it's also quite powerful. And we'll talk about some data in a little bit to do that even around the scary things, the negative emotions, naming that, creating meaningful human connection around that. Speaks to people and can be a form of resilience and actually promote paradoxically well-being. Having a conversation about what are people afraid of may in fact lead to greater well-being than just trying to ignore it because we think it's going to be an uncomfortable conversation.
Reed, I want to mention something that that may be paradoxical or maybe it's not, and I'm curious what other people thought and what you think. Our head of emergency management has been through, this is his career, and he always shuns the concept of being called a hero after working through these events, and really is concerned that all this, using the term of healthcare heroes, et cetera, is actually puts the healthcare workers in a difficult position, in that this is a chosen job for them, and that notion of being a hero for doing what they're doing, when in fact people are still dying all around them, actually creates even more tension for them, more stress. I'm curious as to, so that sort of goes to the recognition piece. I think it's important to recognize people for what they do, but calling them heroes, actually, his attitude is it actually works against us.
Mm-hmm. That's a great question, Mark. Let me bounce that one back to the audience and get people's thoughts.
Reed, I totally agree with Mark, and maybe it's because he and I went to the same graduate program at University of Wisconsin. But I think the appellation of being a hero means that you will fall on the sword. And having every time that you're going to work is that you have to be a hero and put on the hero's outfit and the hero's face, I think really creates a level of tension and expectation. And I think it causes a level of emotional exhaustion.
What do others think?
It's kind of crazy, isn't it? How sometimes we do things that we think are going to be very positive and never really think about the unintended consequences and the downstream elements that could come with it.
Mm-hmm. Yeah, version, Sherry, of the gap that often exists between what we intend to do and how it lands, right? How it plays out in reality. Anybody want to make the case that recognizing healthcare workers, particularly folks on the clinical side as heroes, has benefit for well-being? Just curious if there's a countervailing point of view, and then I'll share my take on it.
So let me give you my other half of it. Recognizing people for what they've done, reinforcing their efforts, and all of that I think is positive. Give them a label that society declares as, quote, you're a hero because you risk your life, in an ongoing chronic way, I think creates tension. I've talked to a lot of people who really want to push back on the fact that in front of their building it says heroes work here, and they really want to push back. But at the same time, appropriate recognition and thanks for the work they've done, I think, is a balance that we have to achieve. So I'll leave it to you and the rest of the group to answer it.
Yeah, so thanks for that, Gene. So I come down in a very similar place. I think this is one of those places where, particularly for those of us in leadership roles, words and language really matter. What we say gets amplified in the culture. And there is, in the science around feedback and human emotion, very clear evidence that if you give praise for a particular behavior, that behavior is likely to get reproduced. That's true for coaching kids in sports leagues. It turns out it's true at the adult level as well. And so one of the places where I think we can bring forward the positive in this sort of set of leadership practices is around being very clear about what we're saying thank you for, and what behaviors we're recognizing that we think are healthy and sustainable behaviors that we want to see more of. Extrapolating that, though, to labels that spread the expectation between what am I able to accomplish as an individual walking into the building and what does society or my leaders or my organization think I should be accomplishing, that actually induces a high degree of stress. And so that's where, in my mind, this gap or this paradox around healthcare heroes has come into focus, that every time I see one of those banners up on the building, I feel like someone with power and the ability to speak or to give voice to that idea who's made that banner thinks that I need to be able to do things heroically that perhaps are not within my grasp. And it feels very different from people coming and saying an authentic thank you for, working an extra hour, or coming in when a colleague of mine had COVID and needed someone, to work his or her shifts, or whatever other activity create the climate and the culture and the organizational wherewithal to get through this. And so I think that distinction is important. And this idea that expectations which feel out of reach for the individual create stress, whereas validation, whether of positive or negative emotion, can actually be helpful. That's one of the concepts I think we can take back into our leadership. Any other thoughts on that particular piece? Because I think it is a very interesting phenomenon that has developed. And the last thing I'll say is I often wonder how much is the heroism language about the people in healthcare and how much of it is about what our society needs in the narrative, meaning we need to tell ourselves that there are heroes out there who are going to somehow rescue us from this thing. Just an interesting side note.
Just a little spin on that. I think our community that we serve perceives us as heroes. So sometimes that signage can be a communication to them. And so long as leaders, we are enabling our staff to understand that being a hero doesn't mean you have a weakness, or, you can't have a weakness. It doesn't mean you can't reach out, and to find ways to support the staff while acknowledging the significant and impactful work they do, I think is important. So I think we have to look and say, is that message for only the people that drive in and work that shift, or is it also an appreciation for those who might not have the right words and understand our community, but do want to recognize us for their appreciation of the value in what we bring?
Yeah, very well said. Thank you for that comment. So really rich discussion here around, how can we support individuals? So we've heard things at the bottom of the Maslow's hierarchy. Can we take care of people in terms of their physical health, their food, making sure that we're, as we can, doing things in leadership and organizational roles that help with housing and financial security, for example. How do we get to belonging? So how can we bring people together and create meaningful connections? If you move farther up the pyramid and you get to things like self-actualization, it's clear that things we can do to help people grow and make meaning are also good for their well-being. So this is another place where I think many organizations have started to say, how can we bring those who might be suffering high degrees of stress, whether they be doctors or nurses or EVS employees or people in supply chain who have really had to tie themselves in knots over and over again to try to make the place, work and to provide PPE for people who are doing work in the clinical units. Can we bring those groups of people together in ways where the sharing then leads to at least a reflection on growth or an identification of what are ways in which we can help people continue to grow through this instead of only hunker down and try to survive until 2021. So some of those things have been studied well, some have not. I'll offer one interesting piece of data. So we have this in the science, and there are organizations that as part of what they're doing around individual well-being have adopted programs focused on mindfulness or meditation or heart math or any number of activities that they think will help people in their resilience and their well-being at work. This was one of my favorites because I must say for quite some time I was very skeptical about meditation as one thing that could be helpful at work. And then I saw this study, which got me thinking. So this was a study done about 6 years ago with combat training in the Marines. And so they took platoons and they randomized them. Half of them got usual intensive training for combat. The other got the usual intensive training for combat, plus they got mindfulness training. And this wasn't, go away and do a mindfulness retreat. This was, we're going to do a structured team-based meditation for a couple of minutes a day. And then they put the Marines into combat simulations where they were ambushed. And this was the part that really got me interested, because in healthcare, I would just ask how many times during the day do we get ambushed by stuff, whether in the clinical setting or in our leadership work. And when we get ambushed, human beings reliably get stressed and our heart rate goes up, our blood pressure goes up. We often feel a host of negative emotions. And we now know in the neuroscience that when you get into that place of being surprised and kind of being back on your heels, decision-making is often not so good. We may say things we regret. We may make choices that we wish we hadn't made, or we may just be paralyzed in the moment when we need to do something that's really important. And so when they studied these Marines who had traditional training plus mindfulness training, the ones who had mindfulness training had much greater what's called elite performer pattern on their functional MRI, where the stress induced higher performance, not lower performance. They actually recovered their heart rate and their blood pressure and physiologic markers like neuropeptide Y, so chemical markers of stress, faster. And they were able to get past the sort of freeze moment of being surprised and move into using the skills and the training that they had sooner than their counterparts. And so just some food for thought that, these things that help individuals, whether it's meditation or whether it's having less financial stress or whether it's the ability to share stories, so that the stress level comes down, that actually plays into our ability to do our jobs in a more productive and sustainable way. So that was the third bucket. So we've talked about digital and physical structures. We've talked about team and organizational climate. We've talked about how we could support individuals. I want to spend some time now thinking about leadership practices that we could bring forward to improve well-being. So any thoughts on leadership practices that you have used or have seen used or have read about that you think enhance well-being of the people doing the work in our organizations every day?
Sorry, visibility.
So what is it about visibility that's good for people's well-being?
I assume there's something about, being along in the trenches with them, caring enough to show up, being able to speak directly to them so people can speak directly back. I mean, I think that there's a number of, I've worked in two organizations back to back, one with a very demonstrative CEO who would, was really out there meeting with people, in the facilities all the time, particularly in times of crisis, and another who's, sheltered. And it's just a very different feel.
Mm-hmm. So thanks for bringing that one forward, Mark. There is something about visibility that's amazingly powerful. And I think it's all the things you mentioned and things that I sometimes still don't understand, but it's one of those if you look at high performing organizations, if you look at things like the Baldrige principles, leaders who are out there checking in on the people, visible to the people doing the work, it's one of the things that creates a substantial difference, not only in terms of the information that leaders hear from people and the conversations that people can have with the leader, but also something about the way the place feels.
Hold on Vacasa for the owners, it's always fucked up.
So we actually had a webinar with North Texas chapter that they sponsored, and one of the speakers from last week was, ask your team, start a meeting with asking your team, what have you done for yourself this week? So you're engaging them on their health and well-being and taking care of themselves.
And what does a question like that do for the team when it comes from the leader?
You're telling them you care about them.
Mm-hmm.
Yeah,
More
if
than
it's authentic, definitely.
I think it's giving them license to take care of themselves,
Mm-hmm.
which oftentimes, you deprioritize your own welfare for the benefit of others. And you sort of assume that if that's everybody, that's the way it goes. And it sort of tells you that you have permission to actually do that.
So I think
And
go ahead, Claire.
clear recognition that people have lives outside of work.
Right.
That this isn't their only world. That it's much larger than that.
Yeah. Yeah. So a simple question, right? That number one invites people to reflect on, oh yeah, am I doing anything? What could I be doing? But more importantly, I think signals that this is important, that people have permission, and that there is, humanity around the person that's bigger than just what that person can do in his or her role in the organization. And I think sometimes there is this implicit sort of creep around, what does the organization expect of me, and how does the organization see me? Am I purely a function of the utility that I bring, or am I a whole human being? A question like that from the leader really changes the paradigm, points it back at the human side, which inherently is a promoter of well-being when we do that.
And maybe share what you have done for yourself and lead by example,
Mm-hmm.
allowing that taking care of yourself is needed, and you share how you take care of yourself, giving them a great example how to do it.
Good. So both the role modeling piece and then sharing, right? Telling a bit of a story about what are you doing to take care of yourself? Really powerful coming from the leader. What else can leaders do to amplify? What are the leadership practices? Aside from working on the areas we talked about before, where you might be working on team climate or changing the organizational structure, what other leadership practices could promote well-being?
I feel like it's always helpful when you kind of bring it back to the macro perspective. There's a lot in healthcare, especially, there's a lot of subject matter experts again. And, everyone's kind of really focused on their area. And if you can kind of help bring everybody up to that, 30,000, 40,000 foot view and say, here's where we're all going together, it kind of enables more collaboration. And even if you have a counter perspective, it's much easier to voice that perspective in that climate rather than feeling like you're in your own echo chamber. Obviously easier said than done.
So thanks for that, Elvin. Yeah, it reminds me of that, there are lots of different paradigms for leadership, but one of the ones I hold on to, which I attribute to John Cotter, although I never saw that he wrote this in anything that I've read of his many articles, was that, leadership in a way is a distillation of the ability to articulate a compelling vision, plus the ability to execute on tasks to get stuff done in pursuit of the vision, plus building and sustaining healthy relationships. So vision, task, and relationship. And that vision piece, so important, particularly in times when there may be a lot of ambiguity or fear or just, anxiety about what's going to happen, to zoom out and to say, here's where we're headed and why. let's not just talk about what we're doing day in and day out. That's an act of leadership, right? That can really bring well-being back to people's lives.
Well, I think also you have to try and use every channel you can to communicate, because I don't think there's any such thing as over communicating in these situations. It's like a lot of times when we go into the hurricane, when we're doing disasters, or let's say Joint Commission is visiting, instead of getting a weekly newsletter out to the employees to let them know what's going on, sometimes it's daily, or sometimes it's the beginning and the end of the day, just so people feel like they are informed and don't feel like they have to read about it in the newspaper tomorrow.
Yeah, thanks, Sandra. It reminds me of a phrase a good friend of mine taught me, that in some ways, dialogue or communication, that's the fundamental unit of work in our organizations, particularly in times like we're going through now. And so that's another way that we can really amplify people's well-being, or in its absence, right, cause stress and burnout. So I want to dig a little bit deeper into this leadership concept. Lots of great examples here. Let me show you one interesting article, and then we're going to talk about one other leadership practice that we'll actually do together as we round out our time. So this was mentioned earlier, but I wanted to call it out. Leaders asking questions, turns out, is a really powerful way that we can either promote stress or promote well-being. So I'll give you a patient safety example. We often talk about leader rounding and going to the bedside or going to where the work is. And the historical, or kind of the traditional frame on patient safety leader rounding has been the top line here. The goal is to get out there and say, what issues do we need to fix? What is going to harm the next patient? What is broken? Very well-intentioned questions. What those questions often lead to, though, is an outpouring of all the stuff that is broken and is going wrong, which on the front lines may feel like a chance just to get into a venting session where we're talking about what doesn't work in the organization. And now I'm really focused on the negative. And then for leaders, can feel really overwhelming, because now I walk back to my office and I get a list of 97 things from today. And when I go do leader rounding tomorrow, I'm going to add another 39. And then by the end of the week, I've got more stuff than I can possibly do and close the loop on with my people. So there was an interesting study done in neonatal ICUs where they simply asked the leader to change the way the question was asked. To change it to this, what are 3 things that are going well around here, and what's 1 thing that could be better? So a balanced appraisal of positive and negative. And then what they did is they came around to the units and they said, did you see your leader, when she or he rounded, asking for information about what is going well in this setting, not only what is broken or what may cause harm? Yes, no, or not sure. And then they measured the presence of that positively framed question against a whole bunch of dimensions of organizational climate and performance. So green bars here are, yes, I saw my leader asking positive questions with high frequency. Red bars, lower. So top quartile, bottom quartile. And so across the boards of the things at the bottom, when they went in and they said, how ready are you for the next improvement project and the next change? If people saw their leaders asking a positive version of the question, improvement readiness was significantly higher. What is your perception of the quality of your local leadership? Much higher if the leader was asking that positively framed question as opposed to the traditional negatively framed question. What's your perception of teamwork climate on this unit? Better if the leader was asking positive questions. What's the safety climate on the AHRQ safety climate survey? Better if the leader is asking positive questions. What's your emotional exhaustion? Lower. What's your burnout? Lower. And then the last one, to me, really kind of blew my mind. People's perception of their own work-life balance was better if leaders were asking a positively framed question compared to a negatively framed question. Now, I would posit that it's also because leaders who do this are probably doing other things that either recognize positive effort or create aspects of workplace climate that give rise to the results we see here. But for me, this was a really interesting reflection of the fact that how we ask questions as leaders is another tactic or tool that can contribute to people's well-being. And this has been, shown in a variety of other studies. This came out in the Mayo Clinic earlier this year, where they looked at, I think it was 35 or 40,000 employees. And basically they just measured burnout and correlated it with the local ranked perception of the quality of the leader that people reported to. And the bottom line is high quality leadership equals lower burnout, or vice versa. So there's something about how people lead that's really connected to well-being and its opposite, burnout. So I wanted to bring our time to a close with one other leadership skill that I think ties several of the themes together we've talked about and has been shown to impact well-being, which is leaders' use of storytelling in the organization. And the key here is that we're sharing a story that focuses on human experience or emotion that I, the leader, have undergone or experienced, much more than a story about tactics or the plan or data. So this is connecting with the heart, if you want to think of it that way. And so I know Anne-Claire communicated with Mark ahead of time to say, hey, Mark, would you be willing to participate in a little bit of storytelling when we do our session on Wednesday night? And so Mark, if you are still willing, I was going to invite you to share, a 2 to 3 minute story, any story you like, about your human experience of leading during this pandemic. What has really touched you? What has stood out to you? Perhaps what has surprised you the most as a leader? If you'd be willing to share a story with us. And I'm going to ask everyone else to listen, and then we'll reflect together on what happened to us as we heard the story. So Mark, would you be willing to share a story?
First off, I do appreciate Anne-Claire asking me to do this. Obviously, you've heard me speak up, so I particularly like it, participating in these things. Story that comes to mind, and it's just because of the pandemic, was a call that I got from a colleague, really distraught. I think the world of her. I think she's an incredibly caring. She herself is a leader. She's a department chair in one of our hospitals, and early on in the pandemic, she lost her father and mother-in-law, former mother-in-law, because they're divorced. Anyway, and so she was, and she's a chair in a department that was very significantly impacted by this. And so we'd been in touch a lot in my trying to be supportive of her as she's, dealing with this. But I get a call from her one day that her nephew, who was a preemie, and was only 4 months old, was actually being admitted to the hospital. And his parents, who are not medical people, were not allowed to actually, they were worried that they weren't going to be allowed to visit, because this is when we had closed down all visitors, even to the pediatric unit. And she wanted to be able to get in and see him. And I listened, and I felt like, I could do a couple of things here. I could pull strings and actually get her to get in there, because they were now letting one parent go in at a time and the other parent couldn't go in. And then, of course, the parents would want to be there together because they were just so distraught. And also would have liked to have had some other familiar face, and she wanted to be there for them. And I had to tell her that, listen, we can do that, but it's, as a leader myself.
Rice.
I'm sorry?
And
we got someone who's
sorry.
off mute.
So as a leader myself, and then compounded by the fact that she herself is also a leader, it would be very visible to do this, and that she couldn't go in there. And she just felt so helpless that, first of all, seeing patients die in the emergency department, but now having 2 family members already die, and now having her nephew being in the ICU was just overwhelming for her. And I had to try to help her understand why this was what this was the way it had to be. And it was just such a heart-wrenching experience. And he fortunately did well and was ultimately discharged, but he was sick for quite a while. And I really just myself, and on so many levels, it was an issue because I worried about our relationship and her understanding this, as well as her relationship with her family, because they wanted her there. It was just such a complex dynamic. And at the end, we're still very close. And I think she's grateful for how I helped her come to the decision that she couldn't go. But that's just one small. I don't know if that's what you were looking for.
That's great. Yeah, thank you, Mark. That's a perfect setup. So thank you for sharing that story and that reflection. So wanted to invite the group, if we could, to reflect on, in listening to Mark's story and hearing that, how did it impact you and your well-being at a human level? What stood out for you in terms of how you were feeling or what you were thinking about as you were hearing his story?
Is this where we speak up, or would you like us to do this via chat?
This would be, yeah, the speak up and group participation portion, and Claire.
Okay. I imagine some folks may choose chat because that was quite the story. And the first thing that occurred to me was just the intense level of humanness of, and having to be in that situation and even think, of course, this could be anyone. This could be you. This could be anyone you care about. This could be anyone who's in this particular situation. And our natural thought is to, given what I have, what resources I have at my disposal, how can I help manage this? And then have to structure it where, well, those rules that doesn't really help you in this case. So that everyone is equal. Everyone is equal. The humanity of it, it's all the same. It doesn't matter where you are. And so the challenge as a leader to be able to communicate that in a very authentic and caring way was remarkable.
Thanks, Anne Claire, for getting us started. So seeing, it sounds like, and hearing and feeling for yourself some of those challenges, connecting with those challenges that Mark described in his own situation. And then imagining, like, how are we going to balance these competing principles, breaking bad news in a way with, taking care of this other person. All of that was encapsulated in a very short story. And that last piece resonated with you as well. What came up for others?
You want me to tell another story, Reed?
Yeah, we should just keep going, Mark.
There's something about knowing yourself that it's worth investing some time and some vulnerability on your own part to be able to help somebody else through a tough decision or a tough time, and being willing to take that step.
Thanks, Sherry. And what is the vulnerability piece? Leadership often comes with, I think, a set of assumptions that being invulnerable or not sharing your vulnerability or your weaknesses is part of what, is expected in the job, or maybe we're afraid of, or people expect in us. What's the value of being vulnerable enough to share a story in terms of impacting people's well-being and how they feel when they come into work every day?
It humanizes you. It makes you one of them. I mean, the whole issue of being vulnerable shows that you're willing to share yourself. And I think as I listen to Mark's conversations and thinking about myself in his position where I was years ago, the story, more than data, more than numbers, more than a bullet point list, really humanized it, personalized it, made it real, and sort of caused those emotions to come out. And that's what I think really came out for me.
Yeah. Thank you, Gary. Yeah, so there's something deeply human and humanizing about sharing, being a little bit vulnerable, tapping into some of those emotions. It does something for us that's a little different than just the data. or just the strategy and the tactics, even though it can feel hard. So thanks, Mark, for being willing to share a story. Wanted to illustrate that experience and also highlight as we close that in the leadership bucket, this idea of how do we cultivate healthy vulnerability? How do we let people show up and share whatever they're going through? How do we facilitate that? We've had several examples in our conversation. Asking questions in a certain way can either increase or decrease the likelihood that we get that human connection. Asking people, what are they doing to take care of themselves? Modeling that as a leader, that can contribute to well-being. But I think there's something quite powerful simply about sharing stories as an act of vulnerability and creating human connection in the work, particularly in the times that we're in now. So another leadership behavior that can contribute to this. So let me bring us to a close here. My hope as we've gone through these different categories tonight, just to put the structure back around it, is to highlight that stress is quite common. I don't think I need to convince anybody of that these days. Stress and burnout are linked. Burnout and performance are linked. And so if we flip the coin over and we ask, what can we do to increase well-being and thriving, to reduce stress, to mitigate burnout, to help people not only in their performance at work, but to help people for the sake of taking care of people, which is what we do in healthcare, that there are a number of different strategies we can pursue, and we can get our arms around those by thinking about this as an ecosystem approach, that working on physical and digital structures can be helpful if that's where there's an opportunity, but we don't necessarily have to stop there just with fixing the EHR. We can also work on enhancing organizational and team climate. That makes a difference for people. And if that's where the good work is, pursue that work. We can do a lot to support individuals. And that is also good and important work, but often can't stand alone. And then there are a number of leadership practices that improve well-being, like we've been talking about tonight. And so that can be a major focus for how we enhance thriving in the places that we work. Ideally, over time, our organizations are able to do all four of these things so that we are supporting and growing the ecosystem. But sometimes you have to pick one or another as a place to start. And with that, I'm happy to wrap up and see if there are any closing questions, comments, or thoughts that people want to share as we end our evening together.
So I'll ask the $64,000 question, and that is, if you can't do them all, how do you know which one to prioritize first?
Yeah, so my take on that, Anne Claire, is that particularly as we are A, trying to take care of people, and B, signaling that it matters, that this is important work in the organization, starting on any of these is better than doing nothing and saying, well, we need to wait another 5 years till we have a big enough budget, or we have enough leaders in place, or we have an organizational strategic planning process that allows us to get all four of these on the map. If you look in the literature, and I've spent quite a lot of time reading about that $64,000 question, if there's one thing you could do that makes the biggest impact on well-being, what is it? Turns out effective leadership basically has a bigger impact than almost anything else. And people, I think, know this instinctively. You can think of times you've been in an organization where the infrastructure was not awesome and the team may have been in terrible shape to start, and individuals were saying, I'm about to quit. You put a great leader in there and well-being will go up. So I think one of the interesting challenges for our time is to not only say, can we find the leaders who figured out how to do this instinctively, but in our leadership development, can we empower all of our leaders to do some of the things that we're talking about tonight, to make them lead and help them lead in ways that promote well-being and not only execution on tactics and strategy. So if you had to pick one, leadership's probably got the biggest impact. But if you don't have a ton of leaders who are there yet, it may be worth working on a number of things while you develop the leadership capacity to do the things we're talking about.
Reed, let me ask you a question. There was, we spent a lot of time thinking about how best to support the workforce and providing mental health resources and things like that, which and maybe that's sort of a, the horse is out of the barn kind of, close the barn door kind of thing. Because a lot of what we just discussed are things that you really need to have in place before crisis. So the notion of psychological first aid and training people just in time on psychological first aid and whether or not that's effective. Now we're talking now about sort of combat experience. We're not really talking about the burnout that's a longitudinal problem for people even without COVID. So, but I'm curious, when you suddenly find that there is a stressful event that, where is there a role for psychological first aid? Is there a role for reaching out to people and offering mental health services? Our experience was that people really didn't want to talk at that point. They open up when they're ready to open up. So what's your recommendation about how to deal with workforce that is acutely traumatized? The worst case scenario that I know of was at New York Presbyterian, where one of the ED docs, the chair of the ED doc at one of the hospitals, committed suicide relatively early on in this. I can't imagine how that workforce coped with that. So I'm just curious, what do you think is the way to help a workforce deal with some of this trauma?
Yeah, this one is, I think, one of the hardest things that we've had to figure out literally in real time, as we've seen not only stress in general, Mark, but to your point, people be unable to work, people commit suicide, other really traumatic situations. I think about it in a couple of ways. The first is there's a spectrum. And so at one end of the spectrum is rescue care. And when people are experiencing the levels of trauma like we've seen this year, although this is a pre-existing problem, like if you look at suicide rates among physicians in the United States, they are disturbingly high, too high. We have to have rescue care in place. When people need it, we need to be able to provide that quickly. Upstream are things that I would sort of correlate in the clinical model to chronic disease management. So if we know you have a stressful job, and this has been a stressful job, for a long time, and particularly this year, what are things we can do to help manage that? And so we know that, for example, some of these leadership practices are helpful. We know that making sure that people have permission to take care of well-being in their own life is helpful, and signaling that that's important to us because we know you're going to have stressful stuff at work and we're going to take care of you. There's also a place there for group activities in trusted networks. So debriefs are really powerful. We do that for codes, but we can expand that idea to a whole bunch of other forms of trauma and micro trauma that happen every day as a way just to kind of help people recover and make sense of what's happening. And then there's a third bucket, which is around prevention. That piece, I think we're still figuring out. What does organizational prevention look like around some of these, some of these components that we're talking through? So that's kind of the spectrum that I think about. And I think as we've learned this year, it's helpful to be trying to work on all three of those, working on prevention and not having rescue care, immediate referrals to mental health, for example, like that's not okay. We need the referrals to mental health, but what are we doing in sort of the chronic stress management frame? I think is an equally important question. The second thing I'll say is that this is one of the places where peer facilitation of conversations that allow people to share what they've experienced and feel heard, but not like there's some thing that's going to get fixed, has been shown to be really helpful. We know this for adverse events in medicine, that if there are, if I have a doctor friend that I can just sit down and say, can I just tell you about my experience? And that person listens and kind of validates that that's really helpful. Same thing for nurses, there's literature around that. So how do we build more of that capacity in our organizations? Right now, we often don't do that. We wait until people really wave the white flag and then we rush in and try to, take care of them when we see sort of extreme symptoms of stress. So that's the other thing that I think about. That's hard to do because it's hard work, it takes time. Often it takes resources. People have to have the ability to know who to contact, and there's got to be a time and space for, people to do that sort of work. But we kind of need, in some ways, Ballant groups as a technique, or I kind of almost think of it as a giant palliative care consult. Like, that's a version of what we need, is an opportunity to have a really well facilitated family meeting with some regularity, where we're just talking about what's in front of us and what's been hard and how we feel about it.
Thanks. Thank you.
Any last questions? Okay, well, thank you all for your attendance. Thank you, Reed, for sharing. This is a very interesting, very good conversation. And this concludes our webinar tonight and our last event for this year. Look forward to seeing you all in the new year. Happy holidays and Happy New Year. Take
Thanks,
care.
everybody.
Thanks, everyone.
Thanks so much.
Reed, can you share the slides?
I can. Mark, what would be the easiest way to get those to you?
Probably
Okay,
email.
let me get your email address. 1 second, let me grab it.
And then
Grab
we're
it.
sure. I can type it too.
Go ahead.
Read it.
There, I put it in the chat box.
Read, isn't it the same deck that you sent me?
It is, AC.
Well, I can just send it to Mark.
Oh, do you have Mark's email? Do you mind?
Okay.
Well, yeah, like I have his email by heart.
If it's easy for you to do, go ahead. I don't want you to have to do my email forwarding for me, but
No,
it's literally the touch of a button.
It's autofill.
And we're going to post the recording and the slides so you guys can link directly from your group or to a separate posting. But we have a YouTube channel that we link through our website, so we cache our video content there.
Great.
All right, Reed, thank you so much.
You bet. Thanks, everybody. Have a good evening.
All right.
You too.
Good
Take
night.
care. Bye.